Imagine having a permanent synthetic plastic mesh implanted deep inside your body and then deliberately blasting that exact same structurally altered area with tissue vaporizing lasers.
Yeah, it sounds like a terrible idea, honestly.
Right, on the surface, combining a permanent implant with intense energy-based tissue ablation, it just sounds like a guaranteed disaster.
It really does. And, for years, the medical consensus and some pretty stark regulatory warnings argued exactly that.
The prevailing logic was that mixing these technologies was highly unpredictable and incredibly dangerous.
Mm.
But what if the very same laser technology known to cause severe complications turns out to be the precise cure for the damage it was supposed to cause?
Which is just a massive paradigm shift.
It blows my mind. Welcome to the Deep Dive. Today, we are examining a stack of complex medical guidelines, FDA safety communications, specialized clinic protocols, and this incredible new clinical case study out of Japan.
Thrilled to be here to unpack all this with you. As a researcher in the space, I can tell you these sources are totally upending the conversation.
I bet. So the mission today is to answer a highly specific question for you, the listener.
Right.
Does having pelvic mesh affect your eligibility for vaginal energy-based devices? So things like laser or radiofrequency treatments.
It's a question that completely redefines how we approach pelvic floor health right now. We have millions of women who underwent pelvic organ prolapse or stress urinary incontinence repairs.
Using that permanent synthetic mesh.
Right. Exactly. And now, years or even decades later, those same individuals are exploring non-surgical energy treatments for, tissue laxity or the severe vaginal dryness associated with menopause.
Which makes total sense. They want relief.
Of course they do. But to understand if these interventions can safely coexist, we have to look past the marketing of these devices. We really need to examine the underlying mechanics of what is actually happening in the tissue.
So let's lay that groundwork. What is pelvic mesh, really?
Well, pelvic mesh is typically constructed from a synthetic material. Most commonly, it's polypropylene. And when a surgeon implants this mesh into the pelvic floor, the body doesn't just, ignore it.
It knows there's a foreign object in there.
Right. The immune system recognizes it immediately and triggers a localized inflammatory response. This intentionally forms a dense, fibrous capsule of scar tissue that basically weaves its way through the pores of the mesh.
And from what I understand, that fibrosis is actually the entire point of the surgery, isn't it?
Yes, exactly. The scar tissue incorporates the synthetic plastic to create a new, stiff, unyielding support structure for those prolapsed pelvic organs.
But the trade-off is that it permanently alters the mechanical environment of the vaginal wall. The tissue loses its natural elasticity, its vascularity changes.
It becomes a completely different landscape, biologically speaking.
Right. Then, on the other side of this collision, we have vaginal energy-based devices, or EBDs. These interventions, whether they're ablative CO2 lasers, non-ablative ERYE lasers, or radiofrequency devices, they all rely on one core thing.
Delivering controlled, targeted thermal energy directly into the vaginal canal.
Right. The biological goal is to create a thermal injury or thermal stress that forces the body to remodel tissue, synthesize new collagen, and generate new blood vessels.
Which is great for native, healthy tissue.
Mm-hmm.
But treating a fundamentally altered, heavily scarred, and mechanically rigid environment with intense thermal ablation, that is highly unpredictable.
Okay, let's unpack this with an analogy, because I think it helps visualize the risk. If mesh is basically a permanent plastic screen embedded in scar tissue, and these devices work by blasting heat, isn't mixing them like microwaving a dish with a hidden piece of metal inside?
That is a very accurate way to look at it. The tissue surrounding the pelvic mesh no longer behaves like native tissue.
Because of the scarring.
Exactly. It has a completely different density, a different water content, and crucially, a compromised blood supply. This physical reality is really the foundation for the intense scrutiny surrounding these procedures.
And the FDA hasn't been quiet about this, have they?
Not at all. In July 2018, the FDA issued very specific, stark public warnings regarding the safety of surgical mesh complications.
While simultaneously warning against the unproven use of EBDs for cosmetic vaginal rejuvenation, right?
Yes. So the convergence of a compromised anatomical structure and aggressive thermal intervention creates this uniquely hazardous clinical scenario.
And that hazard translates directly into strict exclusion criteria in the real world.
Hmm.
I was looking at the standard protocols, like the clinical guidelines we pulled from the Women's Health Clinic.
Right, their screening is intense.
It really is. A history of pelvic mesh completely changes a patient's clinical context.
Yeah.
You can't just, walk into a standard cosmetic clinic or a medi-spa and request a laser treatment if you have a synthetic implant.
Definitely not. The guidelines mandate a highly specialized, anatomy-aware review by a qualified expert before any energy treatment can even be considered.
And for certain devices, the door is just completely shut, like the clinical safety guidelines for the Mona Lisa Touch.
Which is a very widely used fractional CO2 laser, by the way.
Yeah. Their guidelines explicitly list a history of reconstructive pelvic surgery with mesh kits as a hard contraindication, a total ban.
And it's not just the clinics. Clinical trials testing fractional CO2 lasers also routinely exclude any patient with previous pelvic mesh surgery from participating.
So why the strict ban from some of these device makers? I want to push back on the mechanics here. Is it just because the tissue is stiff, or is there a specific physical danger?
There is a very specific physical danger, and it's tied directly to the physics of an ablative laser. The key word there is ablative.
Meaning it destroys tissue.
Exactly. It actively destroys and removes tissue. A fractional CO2 laser delivers energy that is highly absorbed by the water inside the mucosal cells.
Okay.
So the energy instantly boils that intracellular water, creating this tiny microexplosion that vaporizes microscopic columns straight through the top layer of the vaginal wall.
Wow. And then the surrounding healthy tissue has to heal those vaporized channels, which jumpstarts the new collagen.
Right, but think about what happens if the vaginal wall is already compromised.
If it's thinned out from menopause
Hmm?
or heavily scarred from prior mesh surgery.
Exactly. Using an ablative laser in that environment is dangerous.
It's essentially like power washing a very thin layer of soil right off a buried plastic pipe. You're intentionally vaporizing the protective superficial layer of the vaginal tissue.
That's exactly what's happening. And vaporizing that protective barrier is the direct mechanism that leads to mesh erosion.
Oh, wow.
Yeah, because the tissue over the mesh is often already stretched thin by the underlying scar capsule. So the ablative laser can easily burn away the remaining barrier, leaving the synthetic polypropylene material totally exposed to the open vaginal canal.
That sounds horrific. When the mesh pokes through the vaginal wall, it must become colonized by the natural bacteria in the vagina, right?
It does. And this leads to chronic, low-grade infections, persistent foul-smelling discharge, and spontaneous bleeding.
I read through some of the reports in the MIUDE database, the one the FDA uses to track adverse events.
Oh, those are tough to read.
They really are.
Yeah.
There are numerous reports of patients suffering from excruciating nerve pain and severe pain for their partners during intercourse, too, all stemming from this exact type of laser-induced mesh erosion.
So, ablative lasers are fundamentally incompatible with the altered anatomy of a mesh patient. They physically destroy the only tissue keeping the implant safely buried.
But the EBD market isn't just ablative lasers. We also have radiofrequency, or RF technologies, and those rely on entirely different physics.
Right. Devices like Thermiva, they do not vaporize tissue.
They use alternating electrical currents, right?
Mm.
So the electrical resistance of the vaginal tissue itself generates the heat. It gently warms the tissue from the inside out to stimulate collagen without breaking that surface mucosa.
Exactly. And because the surface remains physically intact, the clinics utilizing RF suggest that patients with mesh can potentially be treated safely.
Okay, so that's a pretty massive distinction.
It is, but the intact surface only mitigates the immediate risk of physical exposure. The application of RF energy in a mesh patient still carries an immense caveat.
What kind of caveat?
Clinics require the patient to have absolutely zero current mesh complications, no history of erosion, no localized pain, and crucially, they demand explicit clearance from an experienced pelvic surgeon.
So a standard cosmetic provider shouldn't be making this call.
Absolutely not. You see, the alternating electrical currents of an RF device rely on the natural resistance of the tissue to distribute heat evenly. But that dense, fibrous scar tissue encapsulating a plastic mesh, it has a completely different electrical impedance compared to healthy vaginal mucosa.
Ah, so it heats up differently.
Exactly. A pelvic surgeon understands that heating an irregular, highly fibrotic area could lead to unpredictable thermal pooling or even exacerbate underlying nerve entrapment that a cosmetic provider can't even see.
Which brings us to the cautionary tale. To truly understand the gravity of that baseline risk, we found a deeply concerning case study documented in the UK's NICE guidance. That's the National Institute for Health and Care Excellence.
Right, this case really illustrates the danger.
They detailed the aftermath of treating a structurally compromised pelvic floor with energy devices. The patient was a 55-year-old woman with an incredibly complex surgical history.
Very complex.
She originally had a synthetic bladder sling implanted. Later, she suffered from mesh erosion, underwent a complex surgery to remove the exposed mesh, had a biological fascial sling placed, and then required a third operation just to loosen that new sling.
Her pelvic floor had endured a massive amount of surgical trauma. I mean, the scar tissue formation and anatomical manipulation there is just immense.
And then later on, she sought out 3 laser treatments to address vaginal dryness.
And seeking relief for vaginal dryness is a perfectly understandable decision.
Of course.
But applying thermal energy to a pelvic floor that has sustained that level of repeated trauma, it just overloaded her neuromuscular system. The aftermath of those 3 laser sessions was disastrous.
Medical report indicates she developed severe, progressively worsening pain, and sexual intercourse became completely impossible.
Yeah. Upon clinical examination, doctors diagnosed her with a moderate amount of pelvic floor hypertonus alongside levator anyspasms.
The anatomy of hypertonus is terrifying when you break it down. The pelvic floor is basically a complex hammock of interlocking muscles.
Right. It supports everything.
So when a laser introduces intense thermal stress into an area that is already traumatized and scarred, those muscles essentially lock into a localized, permanent fight-or-flight response.
They are constantly and rigidly clenched.
And to manage the sheer magnitude of the pain and the relentless muscle spasms triggered by the laser, she ultimately required the off-label use of intravaginal Valium. Plus, she had to undergo agonizing self-dilation exercises just to try and manually fatigue the muscles back into a relaxed state.
It just highlights the volatility of the tissue. She sought a minimally invasive therapy to restore moisture and elasticity, and instead, the thermal intervention triggered a cascading neuromuscular crisis,
Resulting in debilitating chronic pain.
Exactly. The tissue response to heat, when a patient has a history of synthetic implants and repeated surgical revisions, is simply too erratic.
Okay, here's where it gets really interesting for me. This contradicts everything we just established. If we know that vaporizing tissue over a piece of plastic causes catastrophic erosion,
Right.
and heating a traumatized pelvic floor triggers uncontrollable, permanent muscle spasms, the logical medical consensus should be an absolute, universal ban on all energy devices for anyone with a history of mesh. The risk-to-reward ratio seems entirely broken. Why is there any gray area at all?
Well, for years, the prevailing wisdom was to avoid the combination entirely. But as we know, medical science is rarely static.
Thank goodness for that.
Right. A 2024 clinical case series out of Japan, led by researcher Okui and a specialized team of urogynecologists, completely upends this logic.
It's the ultimate plot twist.
It really is. The researchers fundamentally inverted the paradigm. They took the exact technology known to cause severe complications and utilized a highly specific variation of it to actually treat the most severe cases of mesh erosion.
I was analyzing the cohort for this 2024 study, and the clinical profile of these patients is staggering.
It's a very specific, very severe group.
The team focused on 9 women with an average age of 73. Every single one of them was suffering from severe vaginal mesh erosion caused by polypropylene implants that had been placed anywhere from 3 to 15 years prior.
And the crucial part is that for the majority of this group, specialized doctors had already attempted to surgically remove the exposed plastic, and those surgeries had failed.
Which speaks to how hard it is to remove pelvic mesh. It cannot be overstated. The body's scar tissue weaves through every microscopic pore of the implant.
It does.
Attempting to cut it out, well, the analogy I keep thinking of is that it's like trying to extract rebar from fully cured concrete.
That is exactly what it's like. You risk catastrophic damage to the bladder, the bowel, and the major pelvic nerves. Complete surgical excision is frequently impossible without causing permanent, life-altering collateral damage.
So these 9 women were entirely out of standard medical options.
Completely out of options. Their quality of life was rapidly declining due to constant bleeding, chronic inflammatory discharge, and unrelenting pain.
So because surgical intervention had failed, the urogynecologists turned to an energy-based device to manage the erosion. They utilized a non-ablative ear YAG laser.
Specifically, the Renovolase system.
Right. And they focused the laser irradiation directly onto the eroded exposed mesh and the surrounding necrotic tissue. Wait, so the weapon became the bandage. Using a laser directly on exposed plastic seems completely counterintuitive.
Especially after we just detailed how ablative CO2 lasers actively cause erosion by burning away the tissue sealing.
Exactly. It's like using a controlled backburn to stop a forest fire. How does that even work biologically?
What's fascinating here is the physics. The physics of the specific laser changes the biological outcome. The Japanese team used the ERYOG laser in a strictly non-ablative mode.
So no vaporizing.
Zero vaporizing. The 2940 nanometer wavelength of the ERYOG laser has a very specific absorption profile. When properly pulsed, it's absorbed by the water in the tissue in a way that drives the heat deep into the mucosal and submucosal layers.
Raising the internal temperature rate.
Yes, to approximately 45 degrees Celsius, without allowing enough thermal energy to accumulate on the surface to cause vaporization.
So the surface of the tissue remains completely intact.
Completely intact. The physics prevent the destruction of the superficial mucosa, which is what fundamentally separates this therapy from the CO2 devices we talked about earlier.
That makes sense.
By elevating the internal tissue temperature to that precise 45-degree threshold, the laser initiates a massive biological cascade. The thermal stress triggers a localized upregulation of growth factors and cytokines.
Which promotes neoangiogenesis, right?
Exactly. The formation of entirely new, microscopic blood vessel networks.
It's like using a specialized greenhouse heat lamp. Instead of a laser that acts like a blowtorch burning away the leaves, this specific wavelength gently warms the underlying soil just enough to trigger an explosive root growth right over an exposed pipe.
I love that analogy. The new capillary networks bring oxygen, nutrients, and immune cells back to a chronic wound bed that was previously starving for blood supply.
And what do those new blood vessels do next?
Well, the influx of new blood vessels pulls in fibroblasts. Those are the cells responsible for secreting collagen proteins and rebuilding the extracellular matrix.
So by deeply heating the damaged area without creating an open wound on the surface, the non-ablative laser shifted the localized tissue environment.
Right. It took it from a state of chronic degradation and inflammation into a state of active cellular proliferation. The laser stimulated the body's natural regenerative capacity so effectively that the patients actually grew thick, healthy, newly vascularized tissue directly over the exposed, eroded polypropylene mesh.
That is unbelievable. So instead of subjecting these women to another highly dangerous surgery to try and cut the plastic out of their pelvic floor, the specialized laser therapy empowered their own biology to successfully rebury the implant.
It did, and the histopathological analysis they conducted 1 year post-treatment confirmed the microscopic reality of this regeneration.
They looked at the tissue biopsies.
Yes, and those biopsies showed an organized extracellular matrix and significant cellular repair. The patients experienced a drastic reduction in bleeding and a profound restoration of their daily quality of life.
Which is just incredible for women who were previously told there was nothing left to try. So the clinical distinction between an ablative CO2 laser and a non-ablative ERYAG laser in this specific anatomical context is literally the difference between tissue destruction and tissue regeneration.
It is a brilliant application of biophysics to solve a mechanical surgical failure.
So, returning to the core mission of our deep dive today, does having pelvic mesh affect your eligibility for vaginal energy devices? Absolutely.
Which changes absolutely everything about your biological profile.
Having a history of pelvic mesh definitively disqualifies you from ablative therapies like the fractional CO2 laser because the physics of vaporization will almost certainly expose the underlying plastic implant and cause devastating erosion.
And exploring radiofrequency treatments requires extreme caution. You need a pristine surgical history free of complications and the explicit anatomical clearance of a specialized pelvic floor surgeon.
Right, to ensure the altered electrical impedance of your scar tissue doesn't trigger a neuromuscular crisis like hypertonus.
Yet the revelation from this latest urogynecology research proves that energy devices are not universally detrimental to mesh patients.
When properly selected and applied by an expert utilizing a non-ablative YRA wavelength, thermal energy can actually be the vital therapeutic tool needed to heal the severe mesh erosion that traditional surgery has failed to fix.
Exactly. The exact modality of the energy, the nuanced physics of how it interacts with cellular water, and the deep anatomical expertise of the provider. Those things dictate whether the tissue will break down or rebuild.
You cannot safely apply intense thermal energy to a compromised anatomical structure without understanding the precise physics of the tool you are holding and the cellular reality of the tissue you are treating.
It's all about precision and profound medical knowledge.
Which leaves you with one final provocative thought to mull over today. If medical science has now successfully demonstrated that we can harness advanced, non-ablative lasers to trigger such profound neoangiogenesis and cellular regeneration, that the body can heal irreversible damage and thicken its own tissue over exposed synthetic mesh.
It really makes you wonder about the future.
It does. Could mastering these localized, energy-based regenerative therapies eventually eliminate the need to surgically implant permanent foreign plastics into the human body in the first place?